The Gauteng Provincial Command Council is warning the province could be hit by COVID-19 fourth wave earlier than expected. However, Professor Bruce Mellado says the acceleration of the vaccine drive and following pharmaceutical protocol could stave off the wave.
We predict that the fourth wave is very likely to be triggered sometime between November and January, as we expect quite a number of super spreader events to follow in a row. So that's something that we have to have in mind. So we should not be confused or misled by the fact that we are currently in a situation of low risk. That can change quite rapidly within weeks. As a result of that, the main message from the province remains the same, is that non-pharmaceutical interventions as per level 1 remain in force. It's now extremely important to increase the rate of vaccination and coverage in particular, and especially all the age groups that are more vulnerable to contract severe disease. And we have to accelerate the rate of vaccination in view of the looming fourth wave, support vulnerable populations, and ensure that COVID-19 safe practices are adhered to during campaigning, registration and voting in local elections.
Right, now let's get more details about this. We're joined by a member of the Gauteng Provincial Command Council, Professor Bruce Mellado, as well as vaccinologist, Professor Shabi Madi. Good evening to you both, and thank you very much for your time. Prof. Mellado, let's start first and foremost. Some are saying the wave terminology used to describe the ongoing pandemic has stopped being useful. Rather than talking about in a wave or in between waves or preparing for the next wave, we should be talking about a world where we can prevent severe disease.
Thanks for having me. Indeed, terminology and approaches are always highly debated in the scientific literature and in practice. What's important here, and speaking on behalf of the advisory committee, is what kind of message do we want to put forward in order to alleviate upcoming waves or upcoming increases of cases, having the reduction of severe disease, hospitalization, and mortality in mind. So this is, of course, a combination of many factors, and I speak on behalf of the committee in terms of the modeling, where mathematics and other kinds of analytics have been applied in order to conclude that a fourth wave is actually quite likely in the period specified, somewhere between November and January, and that this basically raises the question, and it reinforces the message that the province has been putting forward, in that we need to continue adhering to social distancing measures, but also we need to accelerate the rate of vaccination so that when the fourth wave comes, we have a lesser amount of severe disease, or people with severe disease.
How complex does that modeling process become now with the vaccinations in the mix, also with a shift in age distribution of cases, with more under 20s being the ones testing positive? And what does that actually mean as far as where the highest exposure is?
That's a very good question. So we started modeling the system already over a year and a half ago. So as we gain more information, as we gain more experience about how the waves behave, of course, the model becomes more and more complicated. And as you correctly point out, the fact that we have now a very important pharmaceutical intervention, the vaccination, that basically creates a set of new mathematics and parameters, and also uncertainties, let's not forget about that go into the modeling. For instance, we not only do we model the number of cases, but now we also use mathematics to model the actual vaccination rate. Where are we going? What is the real rate of vaccination hesitancy? We use artificial intelligence to understand vaccination hesitancy through social media and social sentiment analysis. So indeed, a year and a half into this exercise, clearly the mathematics has become more sophisticated.
Professor Madi, estimates of seroprevalence, or proportion of the population that have developed antibodies, are similarly indicating that there have been 8 times more people infected than the cases that we have been able to detect in the country. So, Prof. Madi, how reliable are these numbers that we are dealing with here to determine whether or not there is a possibility of a fourth wave now in November, or even maybe later in December? All right, we seem to have lost Professor Mahdi then. Let me put that question to you then, Prof. Mellado. The difference in the numbers of the population that have developed antibodies. Some are saying that in fact, the NICD saying they have now discovered that there have been 8 times more people infected than the cases that we have detected. Did you factor that into your numbers?
Okay, I understand Professor Mahdi is back online, but since you addressed the question to me, the answer is absolutely yes. In fact, we've collaborated with Professor Mahdi and his team in order to understand what's the true relationship between what we observe on the ground and the true epidemiological picture of people that contracted the virus but didn't test positive for various reasons. Right. So yes, indeed, that's a very important part of the modeling.
All right, Prof. Mahdi, I think we've got you now back on the line. So let's talk about those complexities. First and foremost, the estimates on seroprevalence, the proportion of the population that has developed antibodies, but 2, the shift in the age distribution of cases. What picture does that paint for us? And should we then be concerned about the behavioral responses to lockdown level 1 that we have seen?
So that's correct. So when we did a sero survey, looking as to what percentage of the population had likely been infected, and this was done before the second wave had actually peaked, around about November of last year and January of this year. At that stage, we showed that roughly about 20% of people in Gauteng had been infected, and that ranged anything from 5% in more affluent areas to as high as 43% in the inner Johannesburg city. After the third wave, all estimates now is that across Gauteng, across the 3 waves, there's probably 75 to 80% of people that have been infected with the virus. Now, that does come with some sort of advantages insofar as people that have been infected with the virus do have some level of protection, at least against severe disease and death from COVID-19. But that doesn't mean that we should become complacent. The impact that the next resurgence is going to have on us largely depends now on what percentage of people, and particularly people above the age of 50, are vaccinated. What we need to target is vaccinating at least 90% of people above the age of 50. That won't avoid a resurgence. A resurgence is almost a given. But what is within our controls is to be able to minimize the overwhelming of our healthcare services and to minimize the number of people that die of COVID-19.
Yeah. So is it good news then, the fact that now we are seeing this shift in distribution or age distribution of cases to more under 20s testing positive, which means the older age group has had higher exposure and have now somewhat built immunity?
So in fact, one of the findings of the survey that we had conducted previously, and which is now again being repeated, is that there wasn't any difference across different age groups as to who was being infected and who was not being infected. Children under the age of 5, as an example, were as likely to have been infected with the virus during the course of the first 2 waves than people above the age of 45. So there isn't too much of a difference when it comes to who has been infected in the past, and it's unlikely to be a difference in terms of who will be infected moving forward. One of the reasons why we are seeing some sort of a shift to more hospitalizations occurring in a relatively younger age group demographic, as has been pointed out, is the role of vaccines. So vaccines were initially rolled out to people above the age of 50 and above the age of 60 as an example. So although we only got coverage of about 55% of people in that age group, that has reduced the chances of them being hospitalized, whilst in contrast, younger individuals had been largely unvaccinated. So proportionally, they're more heavily represented when looking at hospitalization. Yeah. But when it comes to infections, the infections in South Africa has been taking place across all age groups pretty uniformly.
So from the Command Council point of view, these differences in immunity, how are we approaching them? Because, of course, there's been a call to say we need a more agile approach. The national, almost blanket approach is certainly not the one that we should be following. Prof. Mellado?
Okay, I think you're asking multiple questions, actually, not just only one question. So what we do is we collect as much information as we possibly have from 2 main sources. Of course, there is the scientific literature and also the experience from the scientific community in South Africa. And second, we basically gather all the statistics that we can get hold of from the Department of Health, in addition to other sources that we get from other stakeholders, and try to assess what will be the outcome in this particular case of vaccination. How is the temporal evolution of all those differential distributions looking like? What do we expect in the next weeks? What is the real level of vaccination hesitancy? And we basically synthesize that information and give back to government in order to basically refine policy making in regard to the rollout of the pandemic. For instance, as already was stated during the press conference on Monday, it's clear that there are certain sectors of the economy, such as retail, where people that work in retail, they have a lot of contact with other people, work long hours, and they have a great difficulty going to the the vaccination station. So there's a clear need to change the strategy, as already was indicated by the Premier, to basically try to approach and go to the actual places of work, so that these individuals that don't have time or resources to go and take the second jab, or haven't take a jab at all, actually do that. So the Premier basically indicated that there will be a campaign to go to all the main malls and centers of similar activity in order to increase the rate of vaccination. So it's a complex process, and it's basically continuous. I would say it's a continuous discussion that we have with experts and with policymakers to try to refine and improve the uptake.
Professor Bruce Mellado staying on. Professor Shabir Mahdi stays on with us as well. We continue with this conversation. If you've got any direct specific questions that have got to do with the Gauteng province, but also the imminent fourth wave, you can send those through 072-110-5584. We'll put them through to the experts and hopefully be able to provide some clarity for you there tonight. Stay with us. In Focus continues in a moment. Welcome back live tonight on In Focus on Newzroom Afrika, channel 405. The patterns of COVID-19 infections and how that informs what could possibly be a fourth wave and when that fourth wave would hit. What is the data telling us? Professor Bruce Mellado with us tonight, as well as Professor Shabir Mahdi, and taking your questions for the panel, 072-110-5584. Professor Mahdi, in the Eastern and the Western Cape, we first saw an increase of cases at the last, I think the second wave, and Gauteng only saw a rise relatively small, but also much later. However, in the third wave, we saw, in fact, cases past the peaks seen in the first and the second waves. What are the factors responsible for those differences, and what does that tell us about what could possibly be the outcome of the fourth wave?
So that's a really good question, and it's not completely difficult. Well, the main reasons why we're probably seeing differences across provinces is that what is likely driving the resurgence is what is otherwise referred to as waning of immunity. So what we're probably experiencing is that different waves are resulting in different percentage of the population being infected over a different period of time. And that waning of immunity over time starts creating a pool of individuals that become again susceptible to being infected with the virus. As you correctly pointed out, during the course of the first and the second wave, Gauteng was slightly delayed as to when the resurgence started, whereas for the third wave, Gauteng was actually ahead of the Western Cape and the Eastern Cape. But another important dimension is that when you look at the third wave in particular, the provinces that had the lowest number of deaths per 100,000 of the population, as an example, during the third wave, in fact, were KwaZulu-Natal and the Eastern Cape. And those provinces actually had much higher number of people dying as a percentage of the population during the course of the first and the second wave. So what appears to be happening in South Africa, and even within provinces, is that there seems to be a huge amount of heterogeneity as to the amount of infections that's taking place and the period of time over which those infections are taking place. So when we talk of another resurgence, and it speaks to the earlier question that you asked, whether we still require a centralized command council, and the short answer to that is no. What we've seen from the last resurgence is that there's huge variability across the provinces as to when a resurgence really starts, as well as the impact of that resurgence when it comes to hospitalization and death. And the decision-making as to whether we should go to higher levels of lockdown or restrictions really needs to be delegated down to a provincial level. And the only reason why South Africa would ever need to go back to higher levels of restriction is not because we're going to experience a resurgence or when we experience a resurgence, but rather if our healthcare facilities come under pressure, and that would be the only reason. The lockdowns that we've had in the past have had a very nominal effect when it comes to the number of people or the percentage of the population that have been infected on each occasion during each of the 3 waves.
One of the things that points to as a contributing factor, Prof. Madi, to the rapid and very large resurgence in June and July in Gauteng was the dominance of the Delta variant. Are we certain that it's the same variant that will be prevalent during the 4th wave, or is there a possibility of a different variant picking up?
Yes, and that is a complete unknown and almost impossible to predict. Right now in the United Kingdom, as an example, they're experiencing an increase in an evolution of the Delta variant, which seems to be even more transmissible than the original Delta variant. And that is making up about 10% of cases now in the United Kingdom, which is experiencing a resurgence of cases. But that resurgence of cases is not materializing into an increase in number of hospitalization and deaths, which is important. So the mutations that are occurring is completely unpredictable what we'll face in the next 2 to 3 months. And in fact, that will be one of the factors which will influence when we experience a resurgence and the magnitude of the resurgence. And that is further mutations of the virus that either makes it more transmissible or relatively resistant to immunity that has been induced either by vaccination or past infection. So unfortunately, impossible to predict what we will experience in terms of which virus will be still dominating or dominate in November, December of this year, but something that we need to keep an eye on.
Yeah. Population movement patterns, Prof. Mellado, are one of the factors responsible for a possible resurgence. Now, tourism sector, of course, has been pushing for example, the restrictions which were put on South Africans to travel to the UK. Right, to be lifted. Those restrictions have been lifted. As Professor Madi mentions now, the UK is seeing a rise in their daily infections, sitting very close to the 40,000s. How does then that impact on South Africa and what we are likely going to see, seeing that there will be now this movement as airports are getting ready to receive more people to come to the country?
Well, that's a very good question, and I will restrict myself to talking about the Gauteng province. That's what our mandate is. So mobility is absolutely essential when it comes to understanding the evolution of the pandemic and community transmission. We need to understand when numbers go up, what is happening with mobility, and we monitor mobility. We do have access to some decent amount of data that gives us understanding of the amount of mobility and the different types of mobility that we cross-correlate with the evolution of the pandemic. So that's a very important input to the predictions. That's a very important input to understanding whether the data is telling us that there is going to be a new wave of resurgence coming. And it also basically gives us a lot of information as to how to act. So just as an example, the mobility and the numbers that the different sources of mobility data was giving us during, for instance, the second wave or before the second wave allowed us to calculate what will be the impact of mobility between, for instance, KZN and Gauteng, and what kind of measures we will have to implement in the roads in order to ensure that the second wave would not be much, much greater than the first. So mobility did play a very important role because we know how many people are infected in a particular place, we know how many people are infected in the other, and we know people's movement. And yeah, indeed, it does play a very, very important role.
Climatic factors, it's going to get warmer, maybe even get rains in certain parts, as we are seeing some heavy rains in parts of Gauteng.
So the issue of the impact of climate, temperature, and humidity on the transmissibility of the virus is a highly debated subject. There's hundreds of papers on the subject, but there's no uniformity as to what the impact of those factors are directly. Now, what we do know, however, is that temperature and obviously the rain, not as much humidity, does have a very strong impact on social behavior. In particular, the issue of how do we adhere to social distancing. Just to give you an example, during winter, there were many people in taxis. Taxis were cramped and the windows were closed because it was very cold. And as a result of that, we were able, through studies and through actual data, establish that the movement in taxis and the movement of people in taxis played a critical role in magnifying the community transmission. So factors like temperature, humidity, and rain in particular do certainly have a strong impact on how we behave and how we adhere or not adhere to social distancing.
Professor Mahdi, you're saying new surges are a given and new variants are a given. Booster shots, are they needed?
It depends who we're wanting to target and for what the goal of vaccination is. We need to understand that the primary goal of vaccination is protecting against severe disease and death. All evidence currently indicates that people above the age of 65, especially if they got underlying medical conditions, people with cancer or people with conditions that suppresses the immune system, those individuals should receive a third dose of vaccine. And in a country such as South Africa, it would be much more prudent and much wiser use of vaccine to be dishing out the third dose of vaccine to those individuals rather than targeting children between 12 and 17 years of age with a single dose of vaccine. So yes, unfortunately, it appears that 2 doses of vaccine in that category of individuals above the age of 65 with medical conditions and those with immunosuppressive conditions, that 2 doses is not providing as good protection compared with younger age groups, and they do require a third dose of vaccine. And that third dose of vaccine cannot be delayed until the next resurgence is upon us. For that third dose of vaccine to be of any value, we need to get people vaccinated well in advance of the third wave. And I think that should be the priority of South Africa right now, rather than rolling out vaccine to a 12 to 17-year age group who simply are not at major risk of being hospitalized or dying from COVID-19 unless they also have got underlying medical conditions. Yeah.
12 to 17-year-old cohort, Prof. Mellado, is said to be now getting vaccinated because there's this huge resistance from, for example, the over 20s to take the second jab. What are your what is your modeling and I suppose the technology that you're using saying to us about why there's resistance to take that second jab?
Okay, that's a very complicated question. So we look at two things. First of all, we pay very close attention to the rates of vaccination. We pay a very close attention to the geolocation and the geodistribution of those rates, the distribution according to age brackets, and also, unfortunately, we have gender imbalances as well. And then try to understand through modeling what is the level of hesitancy and understand how the hesitancy plays out in terms of those factors in order to advise government accordingly. Now, another very important piece of information that we have to take into account in order to roll out the vaccine is basically what is the capacity to roll out the vaccine, and that capacity has increased quite considerably. Although I don't want to make comments on how important it is to vaccinate people between 12 and 17, what is clear, however, before the decision was taken, is that even if those folks, that new demographic comes in to get vaccinated, given the current level of response from the population and the current level of capacity that we have in the system, and I can't speak only for Gauteng, the fact that we have opened to a new demographic will not have severe impact on the ability to administer vaccination to other age brackets. And as Professor Mahdi has correctly pointed out, we still insist that vaccination be taken in particular by those groups and those demographics that are vulnerable to severe disease.
Professor Shabi Mari and Professor Bruce Mellado, appreciate your time. Thank you very much for joining us tonight here on In Focus.